I just don't understand how any of it works because they make the language so complicated that a regular person, and I mean, I have a college education plus, I can check that box, and I still don't understand what they cover. And I mean, for you, Dr. Cooper, you've got plus, 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 and it's still confusing for you and a staff of people. So this is it is a very nebulous thing, and they know it.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's so great to see you two. Welcome.
Hello.
Hi.
All right, on the show this week, insurance barriers to metabolic health. This is a super important topic because a lot of times we can't get treated the way we want to without the blessing of our insurance companies, and it's getting more complicated, it seems like, every year. So, Dr. Cooper, I'd love if you could just kind of set the playing field when it comes to the role that insurance companies play just in American healthcare in general.
Well, they play a really, really dominant role. In fact, it really can be crippling if the insurance company is not on board with the treatment that you have outlined for your patient. And I've noticed it change over the years because, as you know, I've been doing this for quite a while. And I got into metabolic medicine way back in 1999, I think, is when I first started really focusing in on it. And at that time, nothing really was objected to by the insurance companies. I remember a sense of freedom of being able to really offer patients what you felt that they really needed. And we didn't see a lot of pushback back then. And even through the early 2000s, there wasn't a lot of pushback. Even when we started to use some of the more expensive medications, maybe in metabolic health, when the first GLP-1s came out in 2005 and the first amylin analogs came out in 2005, we didn't get the pushback from the insurance companies at that point. There weren't a lot of these prior authorizations that we would have to deal with. And prior authorizations are what the provider is faced with when they write a prescription or send a referral for a specific test or a consult, and the insurance pushes back and says, oh no, you have to first get our approval for this. And so we want you to fill out this paperwork and go through these hoops to see if we will approve this for your patient. And those started coming up a lot more as we got into the maybe 2015, 2016, as we started getting further into those years. But it still wasn't too bad until I would say maybe 5 years ago is where we started to see a steady increase in these denials coming through. And in fact, when you look up the research about the prior authorization rates, they seem to be increasing. The initial denials seem to be increasing by about 1% per year up until I think it was 2020. And then they started to increase at a much more accelerated rate. And so in 2020, I think that they were estimating denials, even when you fill out these prior authorizations, being somewhere around 11%. And then I think it was 2023, it was like jumping up to as high as 19%. I mean, it's just really getting out of hand.
And this is stuff that a doctor says, my patient needs this because of this. And then the insurance company says no.
They say no. And it can be a medication. It can be a referral for a test. They say no because it's people that don't have medical degrees that are making this determination. They're not independently determining it. They have actually algorithms that they follow that you have to go through these different hoops, but it's not transparent either. And a lot of the things, the steps in the hoops make no sense for your patient. So, for example, they may say you have to try like 6 different medicines first before you can get the one that the doctor's recommending. And your doctor may know that those medicines would be terrible for you or far inferior to the one that they need to put you on to get the results that you need, so that you'd be wasting time and your health would be deteriorating. And there's no doubt that people's health does deteriorate due to these delays. I mean, it definitely does, because once the prior authorization process is in place, patients are waiting for their medication, and they're hopefully waiting while the providers are a little bit more realistic and thinking this probably won't go through. But they try their best, and then there's a denial. And then the patients are often told by their insurance company, well, your doctor can file an appeal. And what the patients don't know is that the appeals are denied at super high rates too. And that unless you have some new information that you can put in the appeal that you didn't include in the original prior authorization process, you don't really have a chance of getting approval on an appeal. But we try to explain this to the patients, but they still want us to try to go through these hoops. And so unfortunately, it's really time consuming. It's bogging a lot of practices down. And I feel that it's insurance companies standing in the way of care instead of providing care. And I feel that it's the insurance companies now that are literally practicing medicine without a license. And I don't know how things have gotten to this level, but we've had about 145,000 healthcare workers leave medicine between 2021 and 2022. And the majority are frontline primary care providers. And they weren't necessarily people that were just ready for retirement. These are including very young doctors that entered with, all the hopes of being able to do some good for their patients, and then seeing the landscape, they just, ran the other way. So it's expected to become even more dramatic in 2023, 2024, once they get that data. So I am really concerned about it. I'm not sure that I'm the one that has the solution, but I hope that patients realize what's going on, because they still have a lot of power. Patients have a lot of power in this, and I don't think they understand that.
I don't think we understand where we can go to do anything about it. It's like, do you go to your congressman? Do you go to the medical board? Like, who is that? Who do we go to? Because it's so frustrating from my point of view, like where I sit, because I've been denied for many things from, over the years from the different insurance companies that I've had to work with. And the process, like, of the denial and the appeals that we've gone through, that's weeks. It's not days, it's weeks. And sometimes they'll only do it through the mail. Like, they won't even do it sometimes over, like in an online situation. They're like, well, we'll send you a letter that tells you if you've been denied. And you're like, what? I'm waiting for medication. Why are you my doctor? My doctor says I need this drug. Who are you? Like, who, and they make it very mystical. Like, they don't tell you what it is. And it's like, why are you saying that I need this drug when my doctor, who I trust, knows better?
Right. And I think also I've noticed that insurance companies, I don't think they're required to tell you what rate of denials they have, for different medications. Because a lot of people see, oh, this drug's covered on my insurance, but it requires a prior authorization. So then the next question you should ask is, what is your rate of denials when doctors do complete the prior authorization process, what percent of those are actually approved versus denied by you after that process? So I think that knowing before you sign up for a plan, if it's an employer plan, you don't really have a choice, or if it's, but if you do have a choice, if you can find out more information about the coverage for different referrals, for in-network, out-of-network, try to really understand what's covered, what's not. And if there's a prior authorization process, tell the insurance company that you need to know the numbers for what percent they deny versus they approve, because that could make a big difference. The other thing I found is when things get out of hand and it gets to this appeal process, it actually helps. We've noticed that patients that are trying to force those appeals themselves, because you have every right as a patient to try to get the appeal, the ones that really are like the squeaky wheel and they will not stop contacting the insurance, asking for supervisors, asking for the highest up person in customer service, and, just relentless, just keep doing that. They sometimes can get these things approved when we can't.
Right.
So I think it's still worth it.
It's hard to get those people, and you have to wait a lot on hold, but it
Yep.
always is good. I always say never go to the first person who answers the phone, because they're usually just like somebody that is a phone answerer.
Yeah, they
You
don't have a lot of power.
No, and they don't have a lot of knowledge usually either. They just
Right.
go by what's in the book that says deny, accept. So
Right.
you have to go to the boss person who basically, I think in their book it says don't let people talk to them. And then you go to the boss's boss. It usually works, but it will take at least a week for it to happen.
Yeah.
I'd like to talk just more generally about the system, and then we'll take a deeper dive into metabolic drugs and treatment and the denials and how to navigate all that stuff. But Dr. Cooper, how much of our medical care system is being wasted when you think about all the person hours it takes to process insurance claims at a typical doctor's office? And then when you take the profits that insurance companies make, that money isn't going for healthcare. That's just going to people who are pushing paper. So when you look at our whole medical system and the amount of money that is spent on dealing with insurance that's not going to healthcare, I mean, what do you think the percentage is?
Oh, it's huge. I know that this is tough, but our healthcare is supposed to be limiting the profits of the insurance companies. I mean, that is what the promise was, is that the new setup that we have had over the last years should be preventing insurance companies from just taking tons of profit. Instead, they're supposed to be putting that back into the care. But I think it's, as you say, Mark, is that they're including all of that paper pushing and objections in part of their expenses for delivering care. And from what I have read, one of the tactics of the insurance companies is, since they have that limitation, I think it's like they can't have more than 20% go to their profits. I think it's something like that. I might be wrong about the numbers. But so what they've done, their tactic is to increase premiums, increase a lot of what people are paying in, so that even that 20% is a bigger number than it would be if they had not increased the premiums and all of that. So they're kind of figuring out a way around the restrictions, and they're profiting more than ever. And the health insurance CEOs have been making just record profits year after year after year since 2020, 2021. Every year they're making absolute record profits. And it's really unbelievable. But I think also the pandemic played a role in the derailing, of the system as well. And I don't claim to understand that. I'm not an expert in insurance at all. But it's another interesting area that the pandemic, because it prevented utilization of certain services for a while, like elective surgeries, and people were not going to get medical care. The insurance companies were making a lot of money during that period of time because they weren't spending it on care, and they were still collecting premiums and things like that. So I think that also played some kind of a role. So it's a tough situation right now, definitely.
So let's flip it and talk maybe about something a little bit positive. What do they cover when it comes to metabolic health? What drugs do they cover? What in terms of maybe a surgical intervention? What do they cover? I mean, I know what they've covered for me, but that's
Yeah.
my personal care. But in general, what do you think they cover?
Well, in general, almost all generic meds are going to be covered because it's really just the price tag that determines whether they are up in arms or create those barriers. So it's not because the drug's not safe or the drug's not effective. It's more just the overall cost of the drugs. So the generic medications are lower cost, and those are always covered without any pushback. And then once you get into more the newer medications that don't have a generic counterpart, now the insurance companies are going to be pushing back. One thing I'll say is that it is opening up a little bit more for employer-based insurance, because I think that the employees have put some pressure on the employers for large organizations to cover more and more of what are termed anti-obesity medications. I don't really like that terminology, but those are where you'll find the more expensive metabolic medications are in that category, and more expensive diabetes medicines are in that category. So I think you're starting to see employers in the financial industry, tech industry, covering more and more the, a greater amount of medication options for people with metabolic dysfunction. And that is something that has kind of waxed and waned over the last several years. But I'd say over the last couple, there's been some momentum in a positive direction. The unfortunate thing is, if you don't work for a large employer and you work for a smaller company, in many areas, I know in our state, Washington State, as a smaller company, you really can't offer your employees that type of coverage. It's not an option for small employer coverage. So if you're on the individual exchange with your own, individual insurance, or you're working for a small company, you don't really even have the option. So you can't even argue for these meds because they're excluded from coverage still. And there's legislation that is pending to try to expand the coverage, but that could take years still.
Let's talk about the classification of obesity. Has that been declared an actual medical condition that is coverable when it comes to these treatments?
Yeah, absolutely. I mean, obesity as a disease came out in 2015, basically. Well, actually, it was even like 1940 by the World Health Organization, I think. But all organizations, including the AMA, finally said, yes, this is a disease. It should be considered medical, treated. The medical treatments should be offered. In fact, the original guidelines in 2015 said that the use of pharmacology in obesity is recommended above and beyond not using pharmacology. So that was their language. It meant that it's the standard of care is to utilize the pharmacology. That was in 2015. And yet the insurance companies were, not on board with that. And even other doctors were not on board with it. Patients didn't understand it. Only now, I think people are grasping that metabolic dysfunction is the disease, and the obesity or diabetes and other metabolic problems are really the symptom, and that there are medications that can really target that underlying metabolic pathology. So I think it's now kind of being embraced a little bit more, but the coverage has always been lagging behind the science.
Because obesity is clearly the reason for so many future diseases, why is there resistance from insurance companies in covering so many weight loss or obesity medications?
Well, it honestly boils down to the cost. And
It's just the money. Always
it
follow the money.
But, if you really worked it out, and this is another thing that in my career, I hate to sound like so old, but going all the way back to the mid 90s, that was when the insurance companies started to see things a little bit more in a short-sighted way. There was a small window before that where there was a lot of talk about preventive medicine. But in the mid 90s, the insurance industry came in and was saying, we need to look at how much money we're spending today. We're not really interested in what the cost savings are in the long run. We just want to know right now how much it's costing us today. And I know that's what they were doing, because that's their communication was really strong in that area. And I think that's just the way they've gone. And I don't see them looking in the long term at all. And I think they're looking at the subscribers as temporary subscribers that are coming and going, between their plan and other plans. And all they are really focused on is what they're spending now. And so they look at the price tag of not just this group of medications, but other medications that are used in, asthma, in immune disorders, cancer. I mean, in a lot of different areas, anything with a high price tag, they're targeting those, and they're going to put up a lot of fuss to try to create a barrier to force doctors to try to find less expensive medication without really considering that in the long run, the healthcare costs will be higher because the patient will have not as, positive an outcome as they would if they were offered the medication the doctor sees best fit for them. So that, I think, is one of the issues, is the short-sightedness and the immediate money that they're spending. But that also, falls on the shoulder of the pharmaceutical industry. We don't understand why the costs are so high in our country for some of these medications. We're just like boggled by it. And if it is something to do with the high costs of drug development in the US, the high costs of FDA approval in the US, those things need to be looked at. And how do we do it in a less expensive way so that that cost doesn't become so enormous that nobody can actually access these very effective medications once they come out?
Well, it sounds like if the insurance company isn't worried about, they're like, well, why should we care about if this is going to help in the future? Well, these people might not be our clients in the future. So why do I care about saving money for the future? Like, I just worried about what they're paying now. 10 years from now, I mean, they might not be on our plan. So why do I care about saving money now, even though they'll be better in the future? But in terms of the FDA thing, I think that that's really a big point, because from what I've read, it costs millions of dollars to bring a drug to the market. So little scientists at their labs,
Mm-hmm.
they're having a hard time bringing new drugs to marketplace.
Right.
So only big companies really can bring a drug that is amazing, like some of these drugs are, which I look at as being amazing, to the marketplace. But these drugs can help so many millions and millions and millions of people. So maybe the way that they can make their money back, because look, we live in a capitalistic society. There's no way around it. Let's face it. That's being American and being honest. But now there's shortages of it because they can't produce enough or whatever. I'm not sure what the real answer is there. Um, but, you know, supply and demand, like they've got to be able to make more. I mean, right now, there's no Manjaro west of the Mississippi. So
Mm-hmm.
if they wanted to make more money, you can lower costs by making more product.
Right.
Um,
I think it's bordering like irresponsible, the whole rollout of medication without a supply, because you have patients. Once again, I always imagine our patients are like forced to be hamsters on a wheel, or
yes.
circus animals jumping through one hoop after another. And the drug companies are playing into that. The insurance companies and the drug companies are forcing the patients to exist that way. And it's so wrong. I mean, they become desperate. You have diabetes and you're out of your medicine for a month and your glucose levels are going up and it's fluctuating. So
That's irresponsible.
yeah. So you prescribe one type of medicine that supposedly is immune to a shortage. And then all of a sudden there's a shortage of that. And you help the patient transition onto a different alternative that supposedly is immune to shortage. And then a few months later, that's a shortage. And now you've got to, and that is just exploding the healthcare costs because every time this happens, the patients have to be seen by their provider to try to come up with a plan B, or their provider has to somehow manage that. And the pharmacies are frustrated. The patients are frustrated. Everyone is really stressed out. And I think that in the long run, we are seeing a deterioration of our health in the US.
I feel like I'm on plan D.
Yeah, we're seeing life expectancy issues. We're seeing increase in disease processes that we didn't have before happening to certain groups of people. And at the same time that we're having an aging population that we're going to be faced with, any moment. So we're just not prepared. And this type of system that is, what we're in is very difficult to navigate. And I think it is, again, circling back to the source of frustration by healthcare providers. Everyone knows the value of primary care providers, but we're losing them at an enormously high rate. And once we've lost a certain number of primary care providers, it'll really, really collapse even more. And so I think if there are any really smart people out there that are high up in kind of healthcare policy planning, I hope that there's some breakthroughs that will be coming soon. But in the meantime, I think it is important to have an advocate on your side, like your healthcare provider that will try to work with you through all this rocky roller coaster that a lot of patients are facing, not just the ones that are in our area for metabolic medicines, but other medications as well. I mean, there are still shortages of mood medicines, ADHD medications, all kinds of things right now.
So let's talk strategy, Dr. Cooper. I know that in the 10 years that you've been treating me for metabolic syndrome, it's happened a number of times where you'll send me a note that says, sorry, the insurance company said that you can't have this drug. So then we have to go to plan B. And it really seems like staying in really close touch with your provider to create that overarching strategy to deal with the system, to say, okay, if I can't get this drug, which is the optimal drug, then I have to figure out what to do next. What's your best advice for patients, Dr. Cooper, when it comes to navigating this system?
I think definitely having, a primary care hub and good relationships with your specialists and your primary care, and understanding a little bit about what they're going through too, because as it is very hard, especially the patients are the most at risk. But the providers too are just beyond their capacity trying to deal with all these problems with all of their patients. So I think have a little bit of heart too, and understanding that they're trying, to work for you. And so I think having that relationship is huge. The other would be your employer. If you have employer-based healthcare, going to HR and explaining to them the difficulties that you're having and getting them to kind of team up with you to inquire with the insurance, what is going on? Why is my employee struggling so much to get the medication they need? And they can actually do something as well. And in some cases, the plan can actually adapt and change for not just a single employee, but the whole entire group of employees to upgrade and to solve some of these barriers once it comes to the attention of HR. So I think that's good for employer-based. And then for the other insurance, it's really being aware of what you're signing up for and asking a lot of questions, understanding it all. It's like, as Andrea always says, it's so confusing. So don't feel bad. Nobody understands it. Don't feel bad if you have to ask questions. Really, no one understands it. So ask, well, what does this mean? This in-network, out-of-network, my out-of-pocket costs, the prior authorization, what are the percent of the prior authorizations in my area of the medication I need? What's the percent that it gets denied versus approved? How I think knowing a lot more. And then if you run into these denials, just being a squeaky wheel with the insurance directly, getting in there and getting to a really good customer service person there. That's, a supervisor. And if possible, even getting a case manager. They have nurse case managers on some of these insurance plans that will also help kind of work with your provider to try to solve some of these obstacles. But I'll tell you, I have some patients where they've had so many obstacles and they cannot change their insurance because, for example, they might be school teachers. I mean, school teachers should have the best insurance in the world. And, and I have some patients that are school teachers and they cannot get like necessary treatment because the insurance will not approve it. And I have other patients where they can't even use a coupon that the drug manufacturer tries to give them because their insurance creates some kind of a weird barrier in there and the pharmacy cannot apply the coupon because the insurance is blocking it. And, when it comes to these things, there's also other groups that are at risk, like Medicare patients. Make sure you look at what kind of plan you're signing up for, because once you have Medicare, you are not allowed to use any manufacturer coupons for any government sponsored plan. So that would be Medicare, Medicaid, TRICARE. And so those patients are really at a disadvantage because they can't even access these coupons. So I think just make sure you have a good relationship with your primary care doc and your specialists, and also with your employer HR department if you have problems, and that you really do understand what's involved in this insurance coverage before you sign up for a plan.
I'd love to kind of wrap things up with this idea that, Andrea and I have been patients of yours for many years, and without treatment for our metabolic syndrome, I think both of us would have probably had some sort of catastrophic outcome at some point.
I think I would probably weigh 500 pounds.
Well, I mean, and it's just,
and
all the diseases that come along with this.
And I would have fatty liver. I would have high cholesterol. I would have like so many problems, and it just would not be a pretty sight, or medically or physically.
And I know that some healthcare plans are incentivizing wellness. But I feel like as a society, we really need to get the healthcare industry to embrace incentivizing wellness, because we have 40% of the population is obese, 50% of the population is either pre-diabetic or diabetic. It seems like if we spent a little more money upstream on these disease states, we would have way less spending when it becomes a critical thing and you have to amputate someone's leg, or you have to treat them for a heart bypass or whatever. It seems so.
You would think so.
Yeah,
absolutely.
I don't know. I know it's a bit of a rant, but it just seems so. This idea of preventive spending is so resisted because publicly traded companies are rewarded for quarterly profit statements and analyst expectations and all that other stuff that happens on Wall Street.
It seems just so short-sighted to me.
Yeah.
It's like it's like exactly what you said. It's like you're thinking of today and not 20 quarters from now.
Yeah.
It's true. I think self-insured companies might be a key. A long time ago, I had a great opportunity to meet with someone from a city program that was noticing that their employees' health insurance costs would start rising sharply 3 years before they were diagnosed with diabetes. And he could literally predict who probably had prediabetes by looking at that curve. And I was fascinated by that. And so I think we're not doing enough of that, even in medicine. I'm fortunate because I have a software program that we've developed as part of just analyzing clinical data in metabolic dysfunction. And I can look at our whole entire group data and individual data. So I can actually see those outcomes for patients. As you know, just like you, we have a lot of patients that have been with us for a decade or more. And you can see that long-term outcome and how great it is in terms of reducing the risk of all of those things: heart attacks, strokes, diabetes, bypass surgery, amputations, all of it. And so I think we don't have that accessible enough, I think, for healthcare providers either, for their own patient populations, because I think if they also were more aware of it, it would help. And then if the insurance companies were actually tracking that type of data over long periods, it would help. But they track data, but not really the kind of information that would really show the cost savings.
Well, I feel like a future episode, maybe we need to get the insurance commissioner on the show, or someone who has spent a career working within the medical insurance industry. We could blur their face so that it could be completely anonymous.
I think it would help. I did actually write a complaint to the insurance commissioner in our state about the top paid insurance CEO in the country. I think it was in 2022, was the insurance CEO for Molina, which is our state-sponsored health insurance for Medicaid and Medicare patients. And he was the highest paid in the entire country. So I thought, geez, this is happening in our state. So I wrote to our state insurance commissioner, and I just got a form letter back that said, we don't control the amount of what insurance companies decide to pay their employees. That's how they responded to it.
Wow.
And I thought that was, so I'm sure if we actually got through to a person, they'd have a better explanation for how this is permitted to have a federally funded program and the person at the helm of that insurance company making the highest salary in the country for a health insurance CEO. And that's right here in Washington State. So I don't really understand that. But my understanding is that a lot of health insurance is federally subsidized. But when it comes to Medicare and Medicaid, I mean, that's our taxpayer funds going straight into that. And so it just seemed odd to me. So I hope we could have a future podcast with maybe either the Attorney General or the Health Insurance Commissioner to explain to us what's going on here.
Yeah. All right. To be continued. Thanks, Dr. Emily Cooper, Andrea Taylor, for another episode of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper, a Work P2P production. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.